Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is Sjogren syndrome, part of our rheumatology revision series. So what is Sjogren syndrome? This is a connective tissue disease with lymphocytic infiltration of the exocrine glands, particularly the lacrimal and salivary glands. It affects approximately 0.1 to 4% of the population, with quite a significant female predominance of approximately 9 to 1. The average age of onset tends to be between the ages of 30 and 50 years. And just looking back to some of the previous conditions we've discussed, approximately 30% of patients with rheumatoid arthritis, for example, also have secondary Sjogren syndrome. The clinical features of Sjogren syndrome are hallmarked by what we call a Sika syndrome, and so this is dry eyes and dry mouth. Dry eyes is also known as xerophthalmia, and this is characterised by patients maybe reporting blurred vision, red eyes, and even photophobia in some cases. Dry mouth is also known as xerostomia, and this can be characterised by halitosis, dental cavities, and adenophagia, or pain on swallowing. Other manifestations of the dryness experienced by people with Sjogren syndrome can lead to vaginal dryness, subsequently leading to dyspareunia, as well as respiratory symptoms, and this can include recurrent respiratory infections, hoarseness of the voice, and dysphagia. People with Sjogren syndrome can have systemic features. They may have an erosive arthritis. They may have Raynaud's syndrome, which is something we've discussed previously in other videos. They may report gland swelling, and a common place for this can be the parotid glands. They may present with a renal tubular acidosis of a type 1 type. They may report neuropathy, particularly a peripheral neuropathy. Vasculitic purpura may be seen, and they also may have lymphadenopathy, and it's important to examine this in patients with Sjogren syndrome, so for example in a PACES scenario, and this is because actually people with Sjogren syndrome do have an increased risk of developing lymphoma, and we will discuss this in a later slide. The investigations of Sjogren syndrome are very similar to those which are done for other people with other connective tissue disorders. We may see an elevated ESR or CRP. When performing a full blood count, we may see a leukopenia or an anemia associated with chronic disease. The ANA is often positive in these patients, and the crucial thing to remember is that the specific antibodies for Sjogren syndrome are anti-Rho and anti-LAR. Rheumatoid factor is also noted to be positive in most people, and you do also tend to get a hypergammaglobulinemia. Other non-blood tests include measuring salivary flow rates. It's encouraged to do this before starting treatment and as part of the assessment of someone with potential Sjogren syndrome. This is known as sialometry. We can also perform something known as the Schirmer test, and this is where a strip of test paper is held up to the lacrimal glands and tested for how much it becomes wet over a given period of time, and less than 5 millimeters of wetting on the strip is indicative of a diagnosis of Sjogren syndrome. A lip biopsy is also increasingly undertaken in these patients, and we're looking for lymphocytic infiltration here when we conduct this test. As I mentioned previously, patients with Sjogren syndrome are at increased risk of developing lymphomas, and this can occur in approximately 2 to 5% of patients. It's also important to remember that mothers with a positive anti-Rho antibody are at increased risk of congenital heart block in their offspring. So these mothers do require closer monitoring during their pregnancies. The management of Sjogren syndrome can be divided into supportive and medical, like most of the diseases we've talked about so far. Supportive treatment takes the form of artificial tears for dry eyes and moistening mouth sprays as well for the dry mouth. Sugar-free lozenges or other gustatory stimulants may be used to encourage saliva production. It's important to periodically swab the palate for candidal overgrowth as well in these patients, again due to the lack of salivary flow. If a patient has got arthritis, then NSAIDs can also be intermittently used for this. In terms of medical treatment, muscarinic agonists may be used, such as pilocarpine for dryness symptoms. Hydroxychloroquine can be useful for arthralgia or arthritis symptoms. There's no firm evidence for the use of other DMARDs, although there's several trials that have taken place or are ongoing. Rituximab is recommended by the European guidelines for severe or refractory systemic disease. So now moving on to some questions. The first question discusses a 25-year-old lady who has a history of Sjogren syndrome. She has recently given birth to a newborn who is noted to have bradycardia and evidence of first-degree heart block on their ECG. Which of the following antibodies is most likely to be positive in the mother? So the options are anti-SCL70, ANA, rheumatoid factor, anti-Rho, and anti-Jo1. So we know that she's got Sjogren syndrome, and we also know from the recent slides that we've looked at that several of these antibodies may actually be positive in someone with Sjogren syndrome, and these include ANA and rheumatoid factor. The specific antibodies you will recall are anti-Rho and anti-LAR. And pertinent to this question, it is anti-Rho that increases one's risk of having offspring with congenital heart block, which is what this newborn has, and therefore the correct answer here is anti-Rho. Question 2. Which of the following renal complications is associated with Sjogren syndrome? So the first answer is renal crisis, which we've heard about in previous videos, which is associated with hypertension. Type 1 tubular acidosis, type 2 renal tubular acidosis, type 4 renal tubular acidosis, or a rapidly progressive glomerulonephritis. You'll recall from the recent slides that we've looked at that the correct answer here is a type 1 renal tubular acidosis. Thank you for listening to this episode of Bite-Sized MRCP. If you like the sound of what you've heard today, give us a thumbs up and make sure you click the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments what you would like to hear about in future in our next episodes of Bite-Sized MRCP, and we will see you for our next episode.